So we look at our last video in the trunk and spine, and we'll look at a supplementary video looking at ventilation, but we're moving down from the cervical spine into the thoracic and lumbar, and we'll look at both of these together. And when we look here, we have the cervical spine that we looked at in the last video, and then we have the thoracic spine, and then we have the lumbar spine, and we have some other things here. We have like a tailbone, it integrates with the pelvis, you have your rib cage, and so you have quite a bit of extra stuff that's going on that play a big role in function and stability of the body. As we can conclude, we had our jaw muscle and our occiput here, and then we had our first 7 cervical vertebrae that we looked at, C1, C2 being unique, and then C3 versus C7. We won't see any more uniqueness in the rest of the body until we come down here to the tailbone, which isn't as functional as the upper body. But then you have your 12 thoracic vertebrae, and you have an opposite kyphotic curve. And then you have your 5 lumbar vertebrae, which then you have again similar to cervical spine, your lordotic curve. Then you have 5 sacral vertebrae that are fused after birth into one. And then you have 4 to 5 coccygeal, your tailbone, that are also fused. So 1 coccygeal, 1 sacrum, 5 lumbar spine, 12 thoracic. And then we can't forget the ribs that are the extension of that thoracic spine. And so we have 1, 2, 3 primary curves that develop as we mature, and that's not how we start, right? You start with 1 curve in the womb, and then what ends up happening as a quadruped, you develop that first primary curve in the cervical spine when you start to get that head control. And then you start to get some standing aspect, and what really allows a infant to be able to stand is the starting of the development of that secondary curve or not. And if that curve's not there, there's not going to be enough balance over center of gravity to maintain gait. And then as you hit your growth phases, those curves accentuate, flexibility, mobility, just kind of shape that a little bit. And then you have your primary curves. And so it's kind of ridiculous when you see these training paradigms that are trying to use things that you're able to do as an infant and toddler and say, well, we got to do that as an adult. Well, I was able to get my knees to my face or heads behind my leg because I only had 1 curve. It was easy to do. And I was able to roll pretty easy because of the mass differential. I can't do that anymore as my mature adult spine. So just a side note on there. But here's your cervical region, thoracic, lumbar. You can see your general shapes. They change. As I mentioned in a previous video, the anterior bodies get larger, and the shape also changes because the function and role changes as well. You can see those curves, the 3 primary curves, the lordotic curve, kyphotic curve, and again a lordotic curve as well. So we'll start with the thoracic spine. And the one thing that we have to consider with the thoracic spine is the presence of the rib cage. And the ribs make a significant aspect, and it's involved in quite a bit of our mobility. These are long levers that connect and articulate directly with the thoracic spine. So the best way of looking at these is nothing more than extensions of the thoracic vertebra. So there's your primary curve. You have 12 of them stacked here. This is protecting, the rib cage is protecting the vital organs. This is where the majority of your life-sustaining organs are at. You can see that they're stacked on each other, and unlike the cervical spine, there's really no difference between T1 and T12 except for that gradual increase with size. But in terms of the shape, is going to be basically the same. You have your anterior body, you have your spinous process, transverse process, and then you have what a little bit different is you have these costal facets that are there to articulate with the rib. And so you have a facet there, and you have 2 of them here, and each rib articulates with both the superior and inferior vertebra. So you have your 12 ribs, 1 for each 12 of the vertebra. Your first 7 ribs are considered true ribs because they have a distinct starting point and end point with their own joint. And then you have what are called false ribs, which are ribs 8 through 10, so 8, 9, and 10. And these are called false ribs because they have a distinct starting point, but they have a shared ending point. So they have this cartilage that comes together, and it comes down and merges at the bottom. And then you have 2 floating ribs, 11 and 12, and they're called floating ribs because they have a distinct starting point, but they have no attachment into the front. And so they serve as big anchor points for some of the musculature, particularly the quadratus lumborum. When you look at the rib itself, you have our articulating head that comes along, and you have this costal cartilage that is a buffer between the sternum, the manubrium sternum, and you have your xiphoid process there, but you can see that's mostly cartilaginous, so it's a very soft component. When you people end up rib fractures, are usually breaking back here in the bony part of it, and you can see this articular head here has this little notch. It has an articular facet that articulates back at the body of the vertebra, and then it has two little notches here for the superior vertebra and the inferior vertebra. And we look at here from a posterior or a superior view, you can see this part here articulating with the vertebra below it, and you can see on the transverse process the articulate. So it has, you have one joint here. You have two facet joints with the thoracic spine above and below it, so 4 there, and then you have 2 here and another one there. So there's a lot of joints that are happening within that thoracic spine, and you kind of see this relationship here. Again, anterior body, 1, 2, 3, 4, 5. I'm sorry, that's the 4th joint that's there, and then the 5th one is right there. And again, one more view. Really nice image here looking at the facet joints for the costal transverse, or the costo. So rib is costo, transverse joint, and then the costo-vertebral joint as well, looking at this articulation. And all of this is here. This joint articulation and ability for movement is to allow this to happen. And this is basically expansion and contraction of the rib cage. And this is how respiration, or not respiration, but ventilation occurs. When we'll talk in that video in terms of when you looked at respiration, we looked at the diaphragm as the primary driver of that. The way that we get air from the environment into our bodies is change in volume, and that change in volume is happening here through the rib cage. So this ability to move, these ribs, their ability to rotate up, so rotate into external rotation, internal rotation, or just up rotation, down rotation, to change the cavity size or volume to allow a negative pressure for air to come in. So when you look here, the ribs can move up and down from the sternum coming up, like what's called the pump handle motion, so that's pulling out, and then the lateral movement of the bucket handle spreading out into that movement. And again, this is happening at these joints that we just mentioned. So each rib is articulating with the thoracic spine and the transverse process, and it's allowing this rotation. You can see the axis of rotation here and here, and it's changing the volume of the air. And so as you are expanding the rib cage, air is coming in, and then as you collapse or compress the rib cage, air is being forced out. And this is driven by the diaphragm, right? So you have your diaphragm moving here. As that flattens out, it's opening the space here, it's drawing air in like a plunger from a syringe. And then as you're exhaling, it's happening there. We'll look at the intercostal muscles and see how that's happening with this rib elevation and depression. So we move away from the thoracic spine for now. We'll look back at the musculature, and we move down to the lumbar spine. And unlike the thoracic spine, where we have rib cage, we have the sacrum. And so unlike the cervical spine, where we're kind of bound by the head and really nothing here, you have the rib cage being bound here, you have the lumbar spine being relatively free, and then the entire spine is based on the foundation, which is the sacrum. And so the sacrum, basically where the sacrum goes, the pelvis goes. Where the pelvis goes, sacrum goes, lumbar spine goes, and it starts that chain reaction. And this is where we get the pelvic neutral and the influence of the anterior and posterior pelvic tilt on spinal position. And as we recall, a posterior pelvic tilt, which is basically extension of the hip, right? The pelvis doesn't move on its own. The pelvis's movement is dependent upon hip position. And so are you looking at the femur moving relative to the pelvis, or in this case, the pelvis moving relative to the femur? A posterior pelvic tilt is basically hip extension and a accompanying lumbar flexion in a relatively close chain. Whereas an anterior pelvic tilt is hip flexion and in relatively close chain, lumbar extension. Your spine and all the way up the kinetic chain from lumbar, thoracic, cervical to head is dependent upon hip mobility and more so pelvic positioning. You can see that the curve of the lumbar spine is similar to that and of the cervical, and opposite to that of the thoracic spine. You have 5 lumbar vertebra, 1 fused sacrum, and 1 fused coccyx or tailbone attached to that. You can see that the gapping between here gets a little, it's tight but about pretty consistent, and then a big gap here between the disc space between L5 and S1, which is also another popular area for herniation, mostly because of our sitting postures for too long. You can see that the lumbar vertebra look basically the same. They get a little bigger as we move down, L5, and then you have the spinous process, and you have a transverse process, and you also have a mammillary process here that serves as an anchor point for a lot of the erector spinae and transverse spinalis muscles. We can see here that the sacrum has a very similar structure. So there's your L5 vertebra, and this L5 articulates with that S1, and you have facet joints there. So it's basically a continuation of the design from head down to tail. And you have your coccyx down here, which anchors on, and it's not an unimportant muscle. All of your pelvic floor musculature anchors to the coccyx at some level. So all of your spinal stability is actually predicated, not all of it, but a lot of it is predicated on positioning of that coccyx, the tailbone. So you have 3 degrees of freedom in the thoracolumbar spine. You have flexion extension in the sagittal plane, you have lateral flexion in the frontal plane, and you have rotation, axial rotation through the transverse plane. You have a supporting ligament structure, and we have this superimposed. You have quite a bit of ligaments for stability from head all the way to tail. The only thing it doesn't continue up is a supraspinal ligament that turns into the nuchal ligament that we talked about earlier with the cervical spine. You have an interspinal ligament between each segment. You have a posterior longitudinal ligament and an anterior longitudinal ligament. And along with the facet joints, this is controlling or limiting the amount of range of motion that you have. And this space right here is the protective shell for the spinal cord. In between each of the vertebrae, you have a disc that has a very dense annulus, or like outside fiber, and you have a softer nucleus in the center that allows accommodation for the movements. But it's a really nice image because you can see the spinal cord there. You can see the ligament and flavum that protects and buffers between the spinal cord and the lamina. You have the posterior longitudinal ligament and the anterior longitudinal ligament that limit or control flexion and extension. When we look at the disc here, you can see the softer shell. This is an exaggerated aspect. It's not quite that soft, but it's fluid, so it's not compressible instead of being air. And you have a very dense, this kind of looks like an onion cut. But this arrangement of this connective tissue, you can see that you have these annulus fibers, that softer pulp in the center, and then you have the end plates that are cartilage between each of the vertebrae. But what's really interesting is this radial alignment of this. You have these different angles that these tissues are there, and this is like Kevlar, kind of help prevent any tissue damage. But damage happens nonetheless. But what can happen over time is that you can get damage of these fibers. And think about what has to happen. You have to get a fissure, a tear that goes through each layer. Each layer has to be broken before it starts to weaken and balloon out, and then eventually rupture and leak into the epidural space. So this is the spine. Here's your disc, and under normal function, you have good normal disc height and no encroachment into the spinal nerve at the nerve root. What happens over time is through poor posture, positioning, this starts to burst through, and it can weaken, damage, and eventually might herniate and put pressure on that nerve. Now you have different levels of degeneration. So you have your normal disc space. Over time you get some arthritic changes. That weakens a little bit. You can get a bulge, but the materials of the disc are still inside the disc. You can get a herniation of the disc where it actually busts through. And then what you end up doing sometimes is you can get a thinning of the disc, which then puts more pressure on the bones, and you start to get osteophytes, or bones that then themselves start to encroach into the epidural space there. So here's kind of looking at the disc protrusion. So that's a bulge. That's a disc extrusion where it sticks out. And then here where you have disc sequestration, where the tissue actually healed itself, but some of that material is still there. So this image here kind of looks at the loading and the spacing that's happening between the discs, the types of loading, that when you put pressure on, when you get vertical loading, it's going to change the mechanics and the loads through that tissue. And what really, like, vertical loading doesn't really affect the disc so much. So it's not that the loads being compressed were the problem. What ends up happening is more movement of the pelvis and rotation that ends up causing more damage. And so these are two different popular researchers that looked at total disc pressure, and they looked at normalization at 100% at just standing, and they showed that, like, obviously laying down or sitting reclined in an appropriate spinal position decreases disc pressure, but sitting and standing and leaning forward, you actually have more disc pressure in sitting than you do in standing. So this is why sitting, especially for prolonged periods of time, particularly sitting and twisting or that posterior pelvic tilt, can be very damaging to the tissue. This is the available motion that we have. You have thoracolumbar extension, you have thoracolumbar flexion, you have lateral flexion left and right, and you have thoracolumbar rotation left and right. And movement for this is coming from both the thoracic and lumbar spine. They both have 3 degrees of freedom, so there's never a plane of motion where one's moving and one's not. Depending upon the arrangement of the facet joints and the limitation of the ribs, that's what's going to maybe limit the range of motion but doesn't disallow that. So you can see you have about 90 degrees, 85 degrees of thoracolumbar flexion. This is assuming you're not getting any movement at the pelvis, right? So you can go into hip flexion and actually get more, but that's actual hip movement and not spinal movement. But the spinal limit based on the interspinal ligament, the facet joints, and the posterior longitudinal ligament, that's limiting the amount of flexion that you have, but both from the lumbar region and the thoracic region. Extension, you have about 35 degrees of extension. You have more in the lumbar spine than you do in the thoracic spine. You're accentuating the curve here, you're flattening the curve there. And here's your extension looking at the sliding that's happening again, not at the disc or the vertebral bodies, but at the facet joints. That's where the movement's actually occurring. Lateral flexion, about 45 degrees. Again, the one side is dropping, the other side's elevating, so you're getting that facet movement. And then we look at rotation, you're getting thoracic movement and you're getting lumbar movement, but because of the way the facet joints are arranged, you're not getting a lot of movement there. You get some, you're getting about 20 to 30 degrees, but most of the rotation is coming from the A1, A2, so the atlantoaxial joint, through the cervical spine because of that 45-degree facet relationship. This slide's a nice slide. It kind of shows the available range of motion. You can see that sagittal plane motion. As with most joints, you have the largest amount of range of motion. You see in the transverse plane that you're not getting a lot in lumbar spine, and you're getting very little to none at the C0, C1, but you're getting a whole bunch, right? More than 50% of your cervical range of motion is happening. Basically, 50% of your rotation is happening at C1, C2, that one joint. And then you can see in the lateral plane, you're not getting so much, but you can see cervical spine is the winner in all three, and that's because of that 45-degree angle of that facet joint. Well, back down to the lumbar spine, we see that this is really contingent upon the position of the sacrum, and the SI joint that's formed between the sacrum and the pelvis. There's not a lot of movement that occurs there. There's a little bit in the sagittal plane. This is basically treated as a fused joint, and so that means that it's dependent upon the motion or movement that's happening at the hip. So any hip flexion, hip extension with the foot that's on the ground is going to be allowed because of spinal movement that's occurring. So let me just reiterate that unless your foot's off the ground in open chain, you're truly getting hip movement, but if your foot's on the ground, any movement of the hip is dependent upon lumbar, thoracolumbar movement. And so you get this nutation, counter-nutation, or posterior pelvic tilt or anterior pelvic tilt based on this counteraction. And so as you go into a posterior pelvic tilt, you're going to get a counteraction or nutation of the sacrum, and a posterior pelvic tilt, you're going to get counter-nutation of the sacrum. And again, it's not so interested in looking at the movements that are here because, again, there's not a lot that's going on. Where you're going to see most of the movement happening is at the femoral acetabular joint, so at the hip itself. So flexion, extension of the hip is the same as anterior, posterior pelvic tilt. Ab and abduction of the hip is a lateral left or lateral right pelvic tilt. And then internal external rotation of the femur is also an internal external rotation, or the left rotation of the pelvis or right rotation of the pelvis. So in this next slide, we're looking at just thoracolumbar spinal flexion. But if we did that, we would not be able to get to the ground. In order for us to reach the ground, we'd have to do some level of thoracolumbar flexion and some hip flexion as well. Since this is open chain, the pelvis and upper body are moving in the same direction. This is ipsidirectional lumbo-pelvic rhythm. In a relatively closed chain, you'll have contradirectional lumbo-pelvic rhythm, which is what we look at when we're looking at standing posture, trying to keep this fixed. And so as you go into an anterior pelvic tilt, that's creating hip flexion. And in order for that to occur, because you're not moving through here, you have to get that motion somewhere, so you're going to go into lumbar extension. If you don't keep the upper body fixed and you allow yourself to go down, this is going to result in this. But the takeaway from this slide is that hip flexion is part of trunk motion. Hip extension is part of trunk motion. Hip ab and abduction, it's because of the pelvis is the base of the spine. And so when we look at this closed chain aspect in the sagittal plane, an anterior pelvic tilt is going to create lumbar extension. It's going to create flexion at the hip, anterior pelvic tilt, and lumbar extension. Posterior pelvic tilt, which is going to create extension at the hip, is going to be lumbar extension. And a left, in this case, a right lateral pelvic tilt, so the right pelvis is dropping, that's creating abduction. and then a opposite side, so a right pelvic tilt with that single leg down is going to be adduction. So the pelvic positioning affects lumbar function, and you want to really know this relationship between here. You also have transverse plane motion with the fixed leg on the ground, left, and if the right leg's on the ground and you're doing right pelvic rotation, that's going to be the same as creating internal rotation. And if you have the right leg still on the ground and you keep the leg fixed and you do external rotation, that's going to be left pelvic rotation. So looking at the fixed leg on the ground and what the aspects happening. So again, you can see the toes are kind of pointing in here. That's internal rotation with the same side pelvic rotation, and then external rotation with opposite side pelvic rotation. So when we truly look at trunk flexion, we're looking at flexion through cervical, thoracic. Here you're looking at extension through the entire spine, hip extension, lumbar, thoracic, and cervical, capital extension. Here you're looking at hip flexion, lumbar flexion, thoracic flexion, cervical flexion, and capital flexion. And so you're going to get this being able to touch the toes because you're allowing the pelvis to anteriorly pelvic tilt, you're allowing the pelvis to laterally tilt, and you're allowing the pelvis to rotate. And again, when we look at the extension, and this happens both in extension and flexion for that lumbo-pelvic relationship. And so you can see different types of rhythms that exist here between lumbar spine and pelvis. You can see like this normal that exists, that you're going to get equal amounts of pelvic tilt with a lumbar flexion. You might see situations like this with like limited hamstring range of motion or hip flexor weakness, and going into not being able to go further down or not touching your toes, right? And this is where people would stretch their hamstrings. Or you can get dysfunctions where they have excessive mobility, some tightness here, usually like an ankylosing spondylosis, some kind of inflammatory disease, or some kind of tightness where you're not able to move the lumbar spine, but you've compensated for insane amount of hip flexion. In closed chain, you can see again what's happening. So when you do this anterior pelvic tilt, you're going with the natural curvature of the spine. The spine is supposed to be in a lordotic curve, and you have that lordosis there, and you have this appropriate disc space here with that anterior translation of the nucleus pulpus, with the pulp going forward. In a posterior pelvic tilt, you can see a counter movement, so you're seeing the opposite. You're going from a lordotic curve to a kyphotic curve, so a flattening out of the lumbar spine, and you're getting this retropulsion of this pulse of the nucleus, and eventually weakening here, and then encroachment into the spine. So when you see this posterior pelvic tilt in a seated position, you can see that it creates flexion through the kinetic chain. And you can kind of now appreciate where this forward head posture comes from that we talked about in the previous lecture, where in order to keep your eyes level at the horizon, you're going to bring your head forward. So you're going to shorten here at the neck. Neck muscles are going to get chronically tight. These are going to be lengthened, and you're going to have some instability then causing down the entire kinetic chain. That's why a sitting posture position needs to be a neutral spine and not a flex spine. And this stability does not come from this enhancement of the lumbar spine. So it's not the lumbar spine that's the issue, right? You can extend all you want all day. It's the pelvic positioning that's the issue. So the reason why this posture is appropriate isn't because they have this lumbar support in the back. That should be a cue to allow you to get your tailbone back, so you're going into a posterior pelvic tilt. So you can see here this sacral angle, and it's called the stack sitting, where you have this aspect that you want to mimic how you're standing. And when you're standing, you don't have your tail behind your legs. But when we go to sit all the time, we tend to do that. And this correction isn't from the extension, it's from the pelvic positioning. And so you're really creating this anterior pelvic tilt to bring the sacrum forward, so that it's the sacrum and the pelvis that's creating lumbar extension, not the muscles here that are forcing you into lumbar extension from this position. This will actually make things worse when you still have that posterior pelvic tilt and you try to go into lumbar extension. You're jamming these up even further. And so this is driven by the musculature. You have your erector spinae, which we talked about. You have your hip flexors and trunk flexors, and then you have your hip flexors here that are pulling into an anterior pelvic tilt. And that's why hamstrings are usually given the bad credit from the passively insufficient aspect, but a lot of times it's from the actively insufficient hip flexors from chronically sitting that doesn't allow us to maintain our anterior pelvic tilt. posterior pelvic tilt, you have your abdominals here, and then you have your hip extensors, hamstrings here, and it's a balance between these two during squatting activities, movement, and your static posture. And so the big focus that you're going to do when we look at like static posture is what position is the pelvis in. It's the most important thing you can look at, and the most important you can look at during dynamic posture, either through gait or through sitting and standing. So as we go through this lumbo-pelvic hip extension, keep in mind that as she goes forward to touch her toes, it is the posterior chain that's doing it. Although you're seeing hip flexion, it's this hamstring, glute max, lumbar extensors that are involved in both going down to touch her toes and coming out of that position. There's a connection between the posterior chain thoracolumbar musculature and through the glutes and down into the hamstrings to control this posterior chain.